And we are going to go to some of our babies and what are the important things that we should know in ROP. So I'm very fortunate to have an excellent team of Sucheta, Dr. Azad, Malika, Narendran, Anil and Tapas. So I think we'll just shift the schedule so that we go from what we see to what we do. So Dr. Anil will be giving the first talk on no ROP. Okay, please come. Please come. Yes. I know Narendra is very busy. Dr. Azad is here.
Thank you, madam, for this opportunity. And I will also thank Scientific Committee AIOS for this opportunity, and I am thankful to my mentors. So we will start with no ROP, and this instruction course is basically meant for a pictorial representation. So some of the pictures in this my presentation are for representation purpose, and they do not exactly represent the patient whom I am talking about. Some of the cases I have used diagram as well. So to start with, I will just have I will not cover basically most of you have been there for last instruction course also, so I will directly go to the screening guidelines and what should be the case based management. So retinal vascularization starts around 16 weeks and it is completed by 40 weeks. So most of the babies, even after birth, they do have a part of immature retina, and part of it is VGF dependent, and the peripheral or the last portion is basically not dependent upon it. So if you go to the screening guidelines, we should know whom to screen for and when the first screening should be done. So rather than confusing all of you about the national international guidelines, we should stick to what we are following in India. As per NNF guidelines, any baby less than 34 weeks or birth weight less than 750 grams, or practically what we right now are following, anyone whose birth weight is less than 2000 grams should be screened for retinopathy of prematurity. So the first screening, as Madam Alwat says that it is for 30 दिन रोशनी के, the first screening should be at least done by 30 days of life, but for relatively more premature babies the screening should be done as early as 2 to 3 weeks of life to identify APROP and to avoid the devastating severe blinding complication. What we have been recently following is many of these babies, they do not stay in NICU for a longer time. Some of them are discharged at 2 weeks or even 3 weeks. So any baby which is being discharged can undergo ROP screening, so that this will help us to sensitize the parents about need for ROP screening, and we are not tend to lose these parents. So coming to the case-based discussion, the first case is basically a 26-weeker. Now what we are seeing in India, young, more preterm babies are getting survived because of better neonatal care. So the first case is 26-weeker baby weighing 780 grams. And the first examination was done around 29 weeks, where the baby's weight was around 760. The baby had lost weight and has not gained it up to 3rd week. Baby was currently shifted on to the back onto the ventilator and had received 2 blood transfusion in due course. The baby also had an diagnosed fungal sepsis and was on IV fluconazole. So if you see the baby, this is the cornea, which is slightly or much hazier that we really expect, and if you see these arrows, they are basically depicting tunicovasculosa lentis, which is also a common finding in very premature babies. So when I looked into the fundus, I could just see these 2 strands of blood vessel. No blood vessel, any part of the blood vessel was not seen on nasal retina. There were only through thread-like structures, and they were not reaching even up to the fovea. So if you see this baby, and if you really have to go for the what kind of management we are going to do for this parent, most important thing is we need to discuss the finding with the neonatologist, that there is need to maintain, at least he should try to maintain the saturation between 90-95. He should not keep on the baby on 100% oxygen, and as far as possible, though it's not always possible from their side, but they should try and attempt the best possible systemic stabilization as early as possible, because it's going to help us to get a stable course of disease. And Importantly, weight gain in the postnatal period is also extremely important. It has been highlighted and it has been published that nutrition and even the breast milk has its own role in getting or preventing to some extent the ROP. So discussing with the pediatrician is utmost important. Next comes is the parental counseling. If you look at the picture, that we know that the blood vessels are hardly in the zone 1, and most probably the baby in due course of time is going to develop some form of AP-ROP or type 1 ROP, which will definitely need treatment. So these patients, the parents need to be primed about the possible AP-ROP and what are the treatment options and outcome that we are expecting. And importantly, the situation in this case really need to be assessed within a week. Practically, I would like to see this baby 3 or 4 days after the initial examination. So this is for the first case. Going back to the second case, it is a 30-weeker baby with a birth weight of 1250 grams, had episodes of apnea and needed supplemental oxygen therapy for duration of 10 days. There was no anemia or need for blood transfusion, but the examination time is at 33 weeks. Currently, baby is gaining some weight and right now admitted to the mother's room for gaining weight. If you see the fundus of this baby, as these arrows, we actually are not seeing any stage of ROP into this photograph, but if you look at these blood vessels, they are either somewhat tortuous. You can see this tortuosity, but this is not either clinically fitting into AP-ROP. There is no stage of ROP, and they are not looking like a normal blood vessel. So in such cases, what we actually should do, again discuss with the pediatrician, and importantly we will need to counsel the patient that the baby will need follow up in the due course, and there is possibility. Looking at the fundus, we can just not surely or 100%, but we can expect that the baby is going to develop some form of ROP which may regress spontaneously or will need some kind of treatment. So need for follow up is this baby, and would like to see this kind of baby in a duration of 1 week, and most probably most of this baby will go on to develop at least a stage 1 or 2 ROP after a week course, depending upon the situation. Going to stage case number 3, it is a 33-weeker baby with a birth weight of 2000 grams. There was no supplemental oxygen needed. The baby has been discharged from the NICU after 5 days. Right now the baby is 37 weeks, and currently the birth weight is, the weight has increased. So if you look at the fundus, besides this small intraretinal hemorrhages, we can see that these normal retinal vessel, they have well transversed into zone 3. They are already into zone 3. The baby is at 37 weeks, free of any systemic complications, is having a stable post discharge course. So what we advise these parents or neonatologists is, there is no need to panic the parents. We just need to reassure them there is nothing wrong in this eye, there is no ROP right now. What we need to do is call you for follow up after 2 weeks, when the baby will be around 39 or 40 weeks, where we expect this blood vessel to grow further, and might be zone 3 will be mature and will not need further follow. So the advice should depend upon the type of situation. Fourth case will be a case, it is another case where there was this mother who had delivery in a PHC, and the baby was then transferred to the SNCU at district hospital. The mother did not have any documented antenatal care. The gestational age was not known to the mother, as she did not know her LMP. Birth weight was 700 grams. The baby had received supplemental oxygen therapy for 2 days, and it was discharged from SNCU after 5 days of course. So right now the baby is 4 weeks. We really don't know about the postmenstrual age, and the current weight has been 1950 grams. So what we see inside is, as this picture is not showing completely vascularization of zone 3, but what we have examined is the blood vessels had reached the temporal ora serrata by the time we have seen this patient for the first time. So this baby basically might be a case of, or most probably is a case of IUGR, and we have screened the baby as the birth weight was less than. So what we need to tell these parents is, there is no further need of ROP screening for this baby, as the zone 3 has already vascularized, and there is no chance that these babies will develop ROP in the due course. Still, we should follow this baby after 6 to 12 months, as most of these baby, they tend to have some kind of visual abnormalities. We should assess their visual acuity at the 6 to 12 months, and if needed, we should do cycloplegic refraction. If we come across any refractive error, we should correct it in time, so that there is, if there is any amblyopic factor, that can be corrected for. So to summarize, the follow-up of this baby with immature retina should actually depend upon the stage of vascularization, which zone of the retina is vascularized as of now, and due consideration is to be given what are the systemic risk factors the baby is having. As in first case, we should screen baby within week, and if the baby is stable, we can prolong the time of follow-up up to 2 weeks also. And follow-up should continue either till there is complete retinal vascularization or at least till 40 weeks of corrected postmenstrual age. Second thing is a good communication with the parents as well as with the neonatologist is very important. Neonatologist can definitely play an important role in preventing this baby going into ROP, or at least getting a less severe form of ROP which may not need treatment. And last thing I'd like to highlight is there is no harm in screening few babies which are actually cases of IUGR rather than missing a single case of ROP which could have detected. Okay. Thank you.
Thank you, Anil, for summarizing and showing all the pictures. I think most important for India and all developing countries is that our mothers don't know their LMP. We don't have gestational age available to us readily. So any screening which is dependent on time of screening versus gestational age is not going to work. And that is why we don't follow the UK or USA criteria, because we cannot tell the mothers and the health workers that, you know, your baby is 24 weeks, it has to come after 7 weeks, and your baby is 25 weeks, it has to come after 8 weeks. So will not happen. So that is why this Tees Din Roshni ke that we have a single benchmark that before 30 days all babies should be screened. But if the baby is leaving the NICU, she's going to mother's house, you know, that is our culture, then they will not come. So one screening before the baby leaves the NICU, if the baby is not going to come back, is a very good strategy. It has been published also by Anand. So we also follow that. So if the baby is around, then between 20 and 30 days is the best time. But if the baby is not going to be around, then one screening before leaving, because then you can give the risk assessment as he showed in his slides, and then you can decide when the baby has to come or doesn't have to come for follow-up. Or you can sensitize the parents that if you are going to Nagpur, this is the person to see there, and this is essential that you follow up with that colleague of mine, you are not coming back to Hyderabad. So that is very important to educate and make sure that the baby doesn't fall through. And Anil, just for you, that now we are following the RBSK guideline, which is the Government of India guideline, which is 2 kg, 34 weeks, without risk factors or with risk factors, and even beyond 34 weeks and 2 kg if there are significant risk factors. So that is the guideline everybody should follow, because that is the only guideline which is accepted in India now. And many countries have their own guidelines, and now we are very fortunate to have our own guideline. Okay, so we'll go to the next talk by, yeah, quickly, till Sucheta gets ready for her talk on ET-ROP type 2. You can answer the question.
Ma'am, in the second case, or sir, there was some amount of tortuosity in the vessels which not vascular, tortuous and dilated like plus. So does it qualify for pre-plus? And if not, like...
So actually the picture would definitely look like a pre-plus disease, but for even a case of pre-plus disease, we will need to have at least some kind of staged ROP to have, or to go ahead for the treatment. We would not expect, because pre-plus along with AP-ROP, the picture will not match. So for pre-plus disease to be called, we need to have at least some form of or some stage of ROP to be there.
Right. So the periphery was, in that case, was was immature.
No,
it was vascular.
So you can have immature retina with a normal dichotomously branching vessels.
Right.
But as the vessels are growing and there is some low amount of VEGF, so there's a natural tortuosity in all immature retinas as they are growing. Okay, so that tortuosity should not be confused with the ROP tortuosity or pre-plus. So as he rightly said, there has to be some ROP, then you can say that tortuosity pre-plus or plus.
Right.
The other very important thing is, if the child is on oxygen, when you are examining the child, then the vessels will be narrow. And there you have to go by tortuosity and not by dilatation, because you can miss that dilatation because oxygen constricts the vessels. And then if the baby is very severely anemic, then the signs may not come up as you would expect. So you have to look at the physical condition of the baby also when you are interpreting the sign, and remember that studies have shown that even for plus, there is between 20 and 40% agreement only among experts.
Right.
So it's more like, if you are not sure, then you follow up and say that okay, it became from pre-plus to plus. But these are very subjective. We don't have objective. There are some algorithms which are looking at measuring actually the tortuosity and dilatation, but most of it is perception. Most of it is subjective by the experts, as you see. So I'm sure that I labeled many patients plus when I started. because I was very worried that, the retina should not detach and I should go ahead and laser, and with time I have sort of moved to the other side, and sometimes now I miss the plus and I think there's no plus because now I'm more overconfident, so that pendulum swings. Okay, but yes, if there's a change from last visit to this visit, then you are more sure that this was pre-plus which changed to plus over.
Sure. Thank you.
Good morning everyone. I'm going to speak on ET-ROP type 2, what are the features and how we manage such cases. So ET-ROP guidelines divide ROP into two types, type 1 and type 2. Type 1 requires treatment, whereas type 2 just needs observation. So basically type 2 disease encompasses zone 1 any stage without plus, or zone 2 stage 3 without plus. So this, if you have a look at this table, this may sound little confusing. However, I will be explaining in detail with the help of pictures in subsequent slides. So what ET-ROP guidelines do not discuss is zone 3 disease, because the treatment is not estimated necessary for such scenarios. However, there are certain exceptions and I'll discuss those as well. And again, there is no discussion on AP-ROP in ET-ROP guidelines because this was added in the classification later than ET-ROP paper. So what factor decides type of ROP? So there is this RM-ROP risk score, which was devised by a group of Dr. Hardy et al. In 1997. This is nothing but a software generated prediction model which decides the risk of progression to threshold disease in a preterm child, and this software makes use of demographic characteristics of the child and the clinical features. So if a child has a score of more than 0.15, you label it as type 1 ROP and treat it straight away, whereas if the score is less than 0.15, you can safely observe such child. However, the authors conclude that clinical examination remains the gold standard. So I'll be showing you the pictures of ET-ROP type 2 cases and also certain cases which fall outside ET-ROP criteria where treatment may be deemed necessary. So the picture on the left is a type 2 ROP. You can very well see the new vessels here in zone 2 posterior. This lesion looks something like a double ridge. So this actually is a very well defined ridge, and this second ridge like lesion which is seen is the advancing edge of the new vessels with some fibrous element in it. That is why it looks like a ridge. And there is definitively more tortuosity in the vessels than normal. However, the posterior pole vessels look quite normal. So we can label this as pre-plus disease. So there is no plus, zone 2, stage 3, maybe 2 or 3 clock hours without plus. So this is a definitive type 2 ROP and just needs to be observed. So we observed this baby and subsequently this disease regressed without needing any treatment. Whereas here the image on the right side is a classical type 1 ROP. You can see all these new vessels, vascularized, red, angry looking ridge, and definitive plus. There is definitive tortuosity of the arterioles in the posterior pole and dilatation of the venules as well. So this baby required treatment. Here is one more picture of zone 2 stage 3. Large part of this disease is in zone 3. However, going by the convention of classifying the disease according to lowest zone, you can see here this part of the ridge is coming into perhaps zone 2 anterior. That is why we label this disease as zone 2 disease, and there is some neovascularization here and definitive fibrous proliferation. So this is a zone 2 stage 3 disease and there is no plus disease in the posterior pole. So this falls under type 2 ROP. Again we observed this baby, this disease regressed, but with sequelae. There was some fibrous scar by the time disease completely regressed. This is one more example of type 2 ROP. This, you can see a faint, very ill-defined demarcation line here, and this part of the demarcation line comes into zone 1 or perhaps at the junction of zone 1 and 2. That is why we've labeled this disease as zone 1. there is definitive peripheral tortuosity of the vessels, but posterior pole vessels are largely normal. So this is zone 1 or perhaps zone 2 posterior stage 1 with pre-plus. Because there is no plus, we did not treat this baby and we observe. However, within a week, this disease progressed and required laser treatment. This is one more example of zone 2 disease, definitive meshwork of new vessels here, and some tortuosity, but not much of dilatation. So again, this is zone 2 stage 3 without plus, type 2 ROP. Sometimes you may encounter cases which do not fall into either type 2 or they don't fall into ETROP criteria. Zone 3 disease is one such example, and rarely you can see elevated new vessels in the zone 3 with some amount of fibrosis and without any presence of plus, and you are in dilemma as to whether to treat or not. So, and there are definitively no guidelines on what is to be done in such cases. So what we follow is, if there is elevated neovascularization with some fibrosis, this, even if the disease regresses, the baby definitely has a risk of fibrous scar developing in future, and that will put the baby at developing long-term sequelae such as RD. So we go ahead and treat such babies. Again, this entity called as smoldering in ROP is a very, very rare possibility, but you can see this in your clinical practice. Typically, these babies present with persistent ridge, which neither progresses nor regresses, and this type of ridge may persist well beyond 48 to 50 weeks of post-menstrual age. Here is an example of smoldering ROP. So this baby was seen at 42 weeks of post-menstrual age. You can see this ridge, and this part of the ridge is into zone 2 anterior. And when the baby was again followed up after 7 weeks, you can see the width of the ridge has little bit reduced. Ridge has turned little whiter, which means it is regressing. There is no vascular activity at all, but it definitely is persistent even at 49 weeks of PMA. So, and again, there are no guidelines as to what is to be done in these cases. So we give option to the parents. If they are ready to come back for regular follow-up, we offer them frequent screening examination. But if you feel that the parents are not likely to come back or are moving somewhere else, and in that case having this ridge persistently for weeks together makes this retina ischemic, and ischemic retina has a risk of getting thinned out in the long term and may develop retinal holes. So we offer laser treatment for such babies as well. So sometimes there are certain other factors which can affect your decision whether to treat or not. Most important is likelihood of compliance to follow, and again the chronological age of the baby, because typically in smoldering ROP cases, as weeks pass by, baby gets bigger, and bigger the baby, more difficult it is to treat with laser, because in India we do it under topical anesthesia, so it becomes technically very, very difficult. So we just need to take these factors into consideration before advising treatment or just a regular follow-up. So to conclude, by and large, type 2 ROP cases require just observation. However, significant proportion of them regress without any treatment eventually. Thank you very much.
Thanks a lot for those lovely pictures and thought process which goes on. I think the ETROP paper also very nicely said, after they defined ETROP type 1, type 2 and said, then there's a paragraph there which says that the decision to treat individual babies does not depend just on the retina findings, but there are other ancillary factors, especially like for the same type of condition, if I see in a 33-weeker, my decision will be different than if I see the same thing in a 40-weeker. So there are, and how's the baby, and whether he's gaining weight, and whether he's still sick. So your assessment of what is going to happen to this is also judged by other factors. And as you rightly said, in our country, because the treatment is not available everywhere, so where the baby is going, and whether everybody is now tired of frequent follow-ups and should we go ahead and laser, or we don't want to laser. So I think the ETROP paper also gives us that leeway that the individual decision to treat will be on the surgeon and will decide, but it's important to follow these guidelines. The other thing important is that these guidelines were made to prevent detachment. So the outcome measure of both cryo-ROP and ETROP was risk assessment for detachment. But our aim here is not only just to prevent detachment, but to preserve a good vision and a good retina also. We don't want to have vitreoretinal scarring or traction and some opacity around the lens. So if we look at is the aim of cataract surgery just to prevent blindness, which you can get 618 or better with ICCE, or is it to give the best potential vision of 6.5 or better without glasses? So if we push our horizon to not just preventing detachment but promoting very good retinal anatomy and vitreous anatomy and preserve a very good vision without any distortion at the posterior pole or any traction or anything, then our thought process becomes little different. But yes, we all follow the ETROP guidelines and then we modify it according to what we understand. So that is why some of the stage 3 we do laser, because we don't want to leave behind any vitreous equally or asequally. Any questions for Sucheta? So while the next speaker, Paraksha, who is going to substitute for Narendran, is getting ready, you can come to the mic. Sucheta, you can take the answer from here.
Yes.
In some cases, we see a tongue-shaped extension into zone 1. I had one case, retrospectively I realized that I had done laser in both the eyes. In one eye, a little portion was left. I was not aware at that time. After discussion with my friend, colleagues, said just a little amount, but when the child came back, they were a little not careful to come back for the follow-up. I saw the child in stage 4A.
Yes. So I think Parag, you can come up. Sucheta, you can come up and say no.
Every little zone was left,
we
but
didn't talk
the
about
truth
how to treat and which area not to leave behind. Maybe you can.
That region in zone 1 is the most important region which needs to be treated very aggressively and adequately. If there is little area left in zone 3, perhaps it does not matter, but little bit of area remaining in zone 1 matters a lot, because that is the most metabolically active part of retina. So even if your laser is fine in zone 2 and 3, that area will keep on releasing VEGF and will lead to non-regression or worsening of the disease.
If you read our paper on treatment technique in IGO, it very clearly says the laser of that area is difficult because OCT has shown there is fluid there and that area is not very mature. So and then the direction of your rays is different for that area than it is for the periphery. So you have to really learn to identify, because everybody is worried that I should not hit the fovea. Yeah. So you have to be very careful and you have to learn how to laser that area. And many times in the first sitting we are not able to laser, but second sitting when the fluid goes away, then you get pretty good burns. Or sometimes you have to use very high energy as compared to the peripheral retina.
And everyone will be afraid to give high energy in that area.
Yeah, so please read that paper. We have
the child will be struggling a lot.
Yes.
And one thing, if I inject little VEGF, anti-VEGF, I mean bevacizumab,
I think that's a totally different ball game. It's not just injecting a little VEGF. Please don't do that. It requires a lot of thought, understanding of what you're doing, what is going to happen. And if you inject, then what is the protocol you will follow? If you don't inject, what is the protocol to be followed? So all the babies of mine, although I don't inject as primary treatment, but if somebody has injected and sent to me, which many people are doing now, they inject and then they say, go to madam for laser. So that's very nice strategy for them. But every baby who has had an injection, there's a big red mark on that file that this baby is post-injection. And we have a very different management for those babies than those who never received. Okay, I don't think we are going to talk of treatment. Now Parag, please talk to us about ETROP type 1. And Dr. Azad, thank you for being here. Please come on the dais.
Yeah. So good morning. So I'm just filling in Dr. Narendran's shoes. I apologize for that, but he's a little busy in the conference. So on his behalf, I'll be talking about ETROP type 1, the clinical features and the management. So again, this slide shows the natural history and the onset of screening. So at whatever birth weight a child is born, the ROP usually starts developing from 32 to 34 post-conceptional age. So it's prudent to start screening at 31 weeks post-conceptional age. And as the disease progresses at around 36 to 38 weeks, around at a mean of 37 weeks is where the treatable ROP is going to appear, and this is where it's prudent to do your examination in this window period, because after that, if it's going to regress, it's going to regress. At this point, if it starts progressing, then by 42 weeks, it will go for blindness. So the screening guidelines in the West is 31 weeks post-conceptional age, which makes sense, or 4 weeks after birth, whichever is later. But for India, it is termed as earlier. And why do we have to be different from the West? I mean, do we see a different set of babies? Are we genetically different? But it's this, that it's because of just the excessive unblended oxygen which we give. So it is, for us, we see a little early because of a little more oxygenation the pediatrician gives, and when the child is out of the oxygen, the disease comes earlier. So it is a little different for us, so we have to start screening a little earlier, and the easiest way would be to screen all the babies by 30 weeks, 30 days of life. So again, just going back, this was the previous cutoff for treatment, the threshold disease, which was defined by the cryo-ROP study, and it was defined as a stage 3 in zone 1 or zone 2, having more than 5 continuous or 8 cumulative clock hours with plus disease. So this was given by the cryo-ROP study in 88. And of course, the ET-ROP, it proved that it is, I mean, we all knew that instead of waiting for threshold, it is better to treat at pre-threshold, and they divided the ET-ROP in pre-threshold into type 1, the high risk, and the type 2. The type 2 has already been wonderfully covered by Dr. Suchita. So what is the type 1? It's, if you see a zone 1 disease, any stage, when I'm talking about any stage, is stage 1, stage 2, stage 3, which you can prevent blindness with plus, it's a type 1 ROP. A zone 1, stage 3, even without plus, falls in this net, and a zone 2, stage 2 or 3 with plus is again type 1 ROP. So this reduces the confusion of number of clock hours, the continuous and non-continuous clock hours, so it has made things a little bit easier. And type 2 was already been mentioned by the previous speaker, that there is no plus in zone 1 with stage 1, stage 2, or in zone 2, stage 3 without plus. This just requires observation, and there's if it only progresses to type 1, then only you do the treatment. So this table shows an easier way of when will you treat and when not, the type 1 and the type 2. So these are the red ones, which are the type 1 ROP. So zone 1, no plus, only stage 3. Zone 1 with plus, any stage you do the treatment. So these are the type 1. Zone 2, no plus, no treatment. And zone 2 plus, only the stage 2, stage 3 require treatment. So coming to the management, so how do we manage? So if we see a zone 2, if it's a stage 2 or 3, then obviously the laser is the first thing, and should be done because it is well away from the fovea, unless what the audience was asking about the notch coming inside. So that's it's very prudent to see that it's exactly what you're talking is zone 2 and only zone 2. But if you see I mean, there are a lot of disease will be in zone 2, but you will see in one clock hour area temporarily it's dipping into zone 1, so that changes the management protocols a little bit. So like I said in my previous talk, that for AP-ROP now anti-VEGF is taking over laser, so that would be the preferred thing, but it should be taken with a pinch of salt. You cannot just give it alters the natural history of the disease. The slide which I showed you earlier, that the threshold disease will come at 37 weeks. If you give anti-VEGF, it is pushed to 60 weeks or 80 weeks. So there is a chance of recurrence, and you have to just see the risk and the benefit. And now in a stage 1, in zone 1, 2 or 3, laser or anti-VEGF, it is debatable. So if it's a classic stage 3, if it's well away from the fovea, laser would be still the preferred choice of treatment. So this is the video showing the laser using the diode infrared laser. And this is just to show you, although it can be done topical anesthesia, you require emergency backup and a pediatrician anesthetist somewhere around. And this is just an infant warmer which we use called the Embrace Nest during the laser to keep the child warm. So you do the monitoring of the child, and this warmer, it has a wax sheet actually, which takes only half an hour to charge, and once it's charged, you just put it inside this jacket, and it maintains a temperature of 36 degrees Celsius for 4 hours. So it's a very good thing, because you want the child to be comfortable, you want the surgeon also to be comfortable, and it sometimes becomes too cold in the air conditioning to put off. So to keep both comfortable. So this is what is an ideal thing which we use here. This is used mainly for the neonatologist to transfer a child from one NICU to the NICU, and it's a mobile thing, so it's quite handy. And the other advantage is that it wraps up the child very nicely and snugly, so there is no sort of movement, and you can really pin down the child, which you want that while doing the laser under topical anesthesia. And of course, we keep the child fasting for 2 hours, and then during the laser, we give a little bit of sucrose or 20% dextrose, 25% for the child to suck. And this is how it looks, the embrace nest. These are all one-time investment, and this can be used and reused for multiple times. The wax sheet has got a life of 1 to 1.5 years, and you might have to change, and it's not very costly. So it is quite, and we can use this in the operating room also while doing vitrectomies, and that's quite a big boon for us, because these children have to be kept warm, and the operation theaters, which are centralized ACs, can be put off for this one case. So this is really good. So this is how laser is done, and you see the aiming beam inside the retina, and you start giving grade 2 to grade 3 burns, which are near confluent and which covers the entire avascular retina from the new vessels to the ora serrata. So it cannot be like a diabetic PRP where you do a one spot width apart. It should be near confluent, half or even less, and the entire avascular retina has to be treated in one shot, and not wait for 2 weeks and come back and do it, because that's going to progress the disease. And if both eyes are required, then both eyes have to be done simultaneously. So the advantages of laser is, of course, it's under topical anesthesia. It can be done even the OPD, but you have to have an emergency backup, and the systemic and the local complications are much less. So just to highlight that in the severe case of ROP like this, where there's a total knockout of capillary dropout, you can't do a laser in such cases. So you have to, so with the, thankfully we have the anti-VEGF. If you do a laser, and this is what could happen, that this is a case which is referred, and you don't know where the fovea is ending, and you can end up actually burning the fovea, and that will be a disastrous outcome of using this laser. So this is where the anti-VEGF has an edge over laser in such severe case of AP-ROP, and you can see post-Avastin the capillary network is growing. At 3 months the fovea is vascularized, and at this time there is no harm in giving the laser if the disease recurs. This is a short video showing the anti-VEGF injection being given. It's a routine procedure like you do in the adults, only thing the dose is 0.02. It's still debatable what will you use, but and at around 1.5 millimeter from the limbus, you just go inside, inject, and come out. There's no need to do any paracentesis or anything, and if you think the cornea has become cloudy, that eye tolerates well, you need not go and do a paracentesis, because we had cases where there has been lens touch after that. And usually we prefer to give both the eyes together if it's required, but there are some people who would not to give both the eyes, they would take a 2 days gap and then give it. So in conclusion, in 1980s, the cryo was the leading mode of treatment. In 1990 to 2000, the laser replaced the cryo, and the cryo actually disappeared. And now in 2010, anti-VEGF is there. So is it going to replace the laser? We don't know. So the answer is that the fight between the anti-VEGF and the laser, who's going to win? Is it going to replace the laser totally, or what's it going to be? So I think the verdict is that they're already falling in love with each other, and I think they're just going to get married, and they both are going to live together happily ever after, because that's the best thing which you can offer for some of these severe cases of ROP. Thank you.
Thank you, Parijat, for an excellent lecture. I think we'll take questions after we discuss the aggressive posterior ROP, because that flows into this. So I request Dr. Azad to please talk to us about more difficult cases and what are the issues involved. Yeah, he was not supposed to talk of ROP, he's supposed to talk.
I think there are lots of courses are there. I don't know how much being delivered and how much is being absorbed. That is also very important. Anyway, we just had a we just had a course before this. Can we have my slides, please? As you know, last session also I talked. I think a couple of people who are there, you know, they may find some repetition, but you know I can't help it, because the topic will remain same. We know what is an aggressive posterior retinopathy of prematurity. Aggressive, you know, the very name suggests it is very aggressive, and it does not conform to any rules. You can't expect, that it will go to stage 1, stage 2, stage 3, and so on and so forth. And it comes in a very fast and a sudden way, and it comes in the zone 1 more often, and very less commonly in zone 2 also. And basically, if it is in zone 2, it is a posterior retinopathy of prematurity. And what is must in this case is, and what is a must? The must is a plus disease. And what is a plus disease? A plus disease is the tortuosity of the vessels of the posterior pole. And what does it indicate? It indicates that the ischemia which was earlier there in the temporal area has now come onto the posterior pole. And therefore it is aggressive. Normally in ROP what happens, that the ischemia is there anterior to the vascularized retina. And from there it comes on to the posterior pole. When it comes to the posterior pole, it becomes a plus disease. And in majority of these cases of AP-ROP, you will see that it is 360. It is 360 all around. You will find on the nasal side, you may find sometimes somebody have a look and he says, okay, it's only 180, he does the laser. But if you leave the other area, that area will progress. And more often, I think most of us who are sitting here, AP-ROP is very often bilateral. Very often what? I think almost 100%. So this means there is a danger to both the eyes. It's not one eye. And this is, the clinical picture. It is in zone 2. If you see, this is the nasal area. If the nasal area is coming here, this means it is a zone 2 aggressive posterior ROP. See the vessels. Can you see the vessels there? See this area. See this all vessels. There's a brush like, they are all going. And it is very aggressive. It is not flat neovascularization. There are certain group of patients where you find flat. Looks, this one kind of a flat. This one is looking like a flat. And what is the other characteristic of AP-ROP? The other characteristic of AP-ROP is here. See, what is this? There's a loop. There's a loop here. There is a loop here. You see this entire area is avascular. And what does it indicate? It indicates that there is a avascular area, there is less of oxygen there, there is less of, more of VEGF production is there, and these areas need to be knocked out when you are doing the laser. Parag just now presented, and these are the areas to be looked into and to be knocked out. Another important, very important thing when you are doing the laser, especially in zone AP-ROP, don't go very close to the macula. Because if you have taken care of the avascular area on the peripheral side, once these areas are damaged and the oxygen supply improves, automatically, the line which you are seeing very close to macula will be, it will be a little bit far away. So don't go very close to the macula. What are the screening guidelines? As I told you, the screening guidelines, I will say, although all of us give a very universal guideline for retinopathy of prematurity, there should be a special guideline for aggressive posterior retinopathy of prematurity. And who are these babies? A 28-week child with less than 800 grams. In my opinion, I think all of my friends and all of us who are in this business, we will do this in 15 to 30 days. I will do it earlier, although Subhadra says 30-day rule. But 30-day rule, I think, will little fall short of the first examination. In that case, we should, especially in cases 28-week child or less than 800 grams, in all these child, the examination should be little earlier, maybe between 15 to 30 days. That is the time when we should, because once you detect, there is no time to follow it up. It goes on very fast in front of your eye. And therefore, 2 to 3 days follow-up is very, very, very important. You can't afford to, wait for, say, a week or 15 days. This is a case, I'll just show you, 26-week child, 980 grams, and presented at 31 weeks. You see this? 26-week child presented at 31 weeks. If it was a 31-week child, it would have presented you at 35 weeks or 36 weeks. That's what I was telling you. And of course, the risk factors are very important. The risk factors are very important, and it is important for our Indian situation. Why it is important for our Indian situation? Because we all say that it is more seen in the heavier babies. Heavier babies, I mean the infants who are born more than, say, 1500 grams, 1600 grams, even 1800 grams. In heavier babies, the risk factors are there. Normally, 1800 grams, 1750 gram is the cutoff of the, our National Task Force guideline, also the Neonatal Forum. But beyond that also we get ROP, and this is because of these risk factors. Sepsis is number 1. Number 2 is blood transfusion. Number 3 is, prolonged ventilation or oxygen therapy for a longer period. So all these factors, they aggravate and they make you believe, they make you think that this child, besides these 2 factors, 26 week and 980 grams, these factors are there, and therefore this will definitely go into a severe ROP, and we need to train our mind to treat this. And as you can see this picture, this is the right eye and this is the left eye. I told you it is a bilateral. And see this posterior pole, see this? The entire area is avascular. Here also the entire area is avascular. We did the laser, and see this picture. Very good. So because if you do the timely laser, and as Parag said, it should be a tight laser. By tight laser I mean the distance should be lesser. Because the disease is aggressive, we have also to be aggressive in the management. Aggressive not only in terms of having all the material and everything, but aggressive in terms of creating the lesion. And this is 4 weeks after laser. Another case, 28-week child, 1070 grams, 33 weeks, and baby was still in this thing, and somebody wrote the pan-retinal laser photocoagulation is needed, PRP. And this is a wrong terminology. Pan-retinal is only used for diabetic cases. It's not for here. Because if you do pan-retinal, you very often damage the retina. And this is the picture. See this. We did the laser. No, the laser was advised. This child was advised laser. And the baby could not come, did not come. Timely laser could not be done, and this is what happened. You can see this. And what is this? This is a closed funnel. Behind this is the optic disc. You can see this area and see this ultrasonography, and this is closed. So now at this stage, nothing, very difficult to manage. Case 3, 27 week, 1100 grams, and as I said, pupil not dilating well. If the pupil is not dilating well, that is an ominous sign. Your child is going into severe ROP. Manage immediately. So sometimes there is a tenuca vasculosa lentis, and the rigid pupil is there, media haze is there. You inject bevacizumab, and then day 3 post-injection, see the posterior pole is clear, little bit, haze is there in the periphery, but that is basically because of the, picture. And these are done, and see this picture. And this is a case 4, again 25 week, 1060 grams, and this infant had a hemorrhage, and we injected bevacizumab. This is, you can just see a small traction, that's all, nothing else is there. And this is, same child, 6-10 weeks later, post-injection, and 43 weeks, see everything is gone in this case. See this area, see this area. See this. So summary, our APROP is a disease of very small and very sick baby. And timely screening and treatment is key to preventing blinding complications. And there's a lot of debate. We had a debate in our IROP society about the intravitreal bevacizumab, or we should use ranibizumab, or now aflibercept is there, should we use that, or whatever it is. But at this point of time, we do use bevacizumab, and it works well. With this, thank you very much for giving this opportunity. Thank you.
Thank you, Professor Azad, for showing wonderful picture and how the babies change with various types of treatment. So any questions to Parag and Dr. Azad basically on the treatable ROPs? So I just wanted to make two comments. One is that, the table which you showed about the, which one to treat and which not to treat. So many of the beginners or even some of the, it becomes difficult to remember what is type 1 topic, what is type 2, stage, zone. So easy way that we also wrote in our joint publication on treatment techniques is that, any plus you need to treat. If you see that table, all plus you need to treat. So even if you're not able to understand, like is it zone 1, 2, is it posterior zone 1, is the tongue going into zone 1 or not. So any plus that you see, and then you have to learn how to look at that plus, we already said that. So all plus you have to treat. And second thing is, as retina surgeon, intuitively all new vessels we treat. So new vessels means stage 3. So all stage 3 you have to treat. The only exception is stage 3 in zone 2 without plus. So those patients you can follow. Otherwise, some of those categories are like theoretical categories, like it says zone 1, no plus. So it's very rare to find, zone 1 ROP without plus, because invariably 90% of zone 1 progresses to the next stage. So you will almost always find plus there. So I think as a practical point, if you see plus, if you see new vessels, go ahead and think that, this is possibly going to treat it. If there are no new vessels and there's no plus, then you need to follow. And as I said, there are some exceptions.
I just had a comment to make for the lasers. I prefer to do the green laser, though I have both, is because the pain is less. We see in our adult patients they are simply unable to tolerate the infrared. So we should keep infrared only for those areas where we do have media opacity or some specific reasons. But otherwise, I think we should conventionally use green laser.
I
Because
think
it's
most
much
of the
less
people have
painful.
now shifted to green laser.
Yeah.
Even in the National ROP Task Force, we have given green laser only to all the NICUs.
Yeah, so that message has to go out, because somehow everybody feels ROP has to be done with infrared, which is extremely painful. And also to get the reaction that we are showing, we need much higher powers.
Yes.
So that would be also disastrous. You would create more breaks, etc.
The other thing is about the timing of screening. So the graph which you showed on the natural history, the ROP will come at 37 weeks where we have to treat, and so we can treat at 31 weeks. So two caveats on that. That graph was made when we were treating at threshold. Now if we are expected to treat at pre-threshold, which will come 2 to 3 weeks earlier than threshold, then our screening criteria has to change. And second thing is that graph was made when we did not have this AP ROP business there. And even American Academy guideline, if you look at that paper, American Academy guideline, which says, treat the young, screen the younger babies later. Then the smallest group, that is 25 26 weekers, it puts an asterisk and below it says footnote based on insufficient data. Because in that data, these small babies and these AP-ROP baby type of babies were not surviving that time. So the sample size was less. So I think we still need to go ahead and think, and especially for AP-ROP, I think AP-ROP needs better classification, because we are still not having the early stage of AP-ROP and how it progresses. So all AP-ROP, how it starts. So I have been discussing with Graham Queen and Dr. Shapiro. So AP-ROP, if you screen these babies at 10, 15 days of birth and then you follow them, then you will see the early stages of AP-ROP before it goes into a detachment and where the outcomes are bad. So if you detect them early, then you can get 80 to 90% outcomes even in AP-ROP. If you wait for 4 to 5 weeks to screen, as Dr. Azad said, we should screen by 15 days. Then we can pick up these AP-ROP cases. And our national guideline also says smaller babies to be screened earlier. And because there you can also modify the course of the disease by talking to the neonatologist and changing certain factors, which you can't do when it's already, now ready to sort of die. So, that is what I wanted to say. So I think.
Excuse me.
Yes, please
I
ask.
just wanted to ask, what is the follow-up schedule when after injecting anti-VEGF?
Tapas, you want to say? I think Tapas has done great work on the follow-up retina after anti-VEGF.
No, there is no definite consensus, and the follow-up schedule is unpredictable. In fact, after injecting anti-VEGF, the disease gets converted from ROP phenotype to a FEVR phenotype to a certain extent. This is one of the issues with these anti-VEGFs. They take a long time to for the retina to get vascularized, and disease can come back at any time, in any way, with many unpredictability. So what I do, if I have to inject and manage the baby only with monotherapy, keep the parents prepared and follow them up till there is peripheral retinal vascularization and there is no comeback.
No, follow-up schedule, most important thing is you should have a longer follow-up. if you have only done anti-VEGF. That's why I always say, if you want to live comfortable and also the parents to be comfortable, after the anti-VEGF, please do the laser. You are happy. So that is the thing. Otherwise, if you just ask what is the monotherapy with anti-VEGF, the follow-up schedule is same as for the this thing.
Yeah, I
But
think
then-
the American Academy now says till 84 weeks. 84 weeks post-menstrual age, in case it is not vascular.
Monotherapy, anti-VEGF, longer follow-up. Even with the laser, it's better to have a longer follow-up. It's better to play safe in this business, of managing a retinopathy of prematurity.
But actually, in the initial days of injecting anti-VEGF, can we give a relaxation period of 2 weeks, after observing at 3 days or after 1 week, if the disease is regressing, so that
Yeah, at least I saw recurrence occurring in 2 weeks and we published that. So I think initially at least every 1 to 2 weeks, and then I think it becomes like the other anti-VEGFs. No, you treat and extend, you treat and extend. So if at 2 weeks there is no recurrence, then you go to 3 weeks.
Laser also, I see patient after 2 weeks, 2 to 3 weeks. Normally you get a reaction if you done the laser. By 3 weeks you get the scar, there. So you get an idea how much laser you have done. Initially, sometimes you may not be able to, whether you have given the spot, but it may not be clear. But later it becomes clear.
that means if I have injected and I have seen the eye is quiet at 3rd day and at 1 week, and then I can just call the baby after 2 weeks.
Yeah, it all depends on also what is the post-menstrual age of the baby when you injected, what was the type of ROP for which you injected, what is the physical condition of that baby, is it still on ventilation, it is still on oxygen, it has not gained weight, or it is a healthy baby now, discharge home and happily gaining weight. I think there are many factors which lead to recurrence after, whether it is anti-VEGF or laser. Your response to treatment doesn't depend just on the eye condition. It depends on so many other conditions. We even showed that maternal anemia, babies born to mothers with anemia have a less vascularized retina in zone 1 and 2 than mothers who were, delivered the same baby, same weight, but they were not anemic. So, we still have many unknowns and some knowns. So I think that, we will learn. It is a learning curve. We all have to learn. Like how does it behave? How does the recurrence look like? Still we are learning how does the recurrence look like. Sometimes we are missing the recurrence. We think everything is fine. But if you see them under anesthesia, you can see that recurrence there. If you had an angiogram, because many people who are using anti-VEGF, they are saying follow up with angiogram, don't follow clinically. But we are not following with angiogram. That will show a totally different picture than if you just saw clinically.
I would rather observe them in 1 week to be safer side than on 2 weeks. I had instances when a 1 week delay converted them, led to traction, and finally we had to operate. Though final outcome was good, so initial stage I would like to be on the safer side.
Quickly.
Since this is a very tough thing to basically manage, because the child has to live a long life and we have to be very sure of whatever we are doing. So I would just request that the experts may kindly distribute the guidelines and also to supplement them with the new things which are coming up, because it is very difficult to keep up with the new things which are coming up for everybody. Some of us may be in the periphery. One more thing I wanted to say is I have undergone laser in my own eyes and I felt that it becomes very painful, difficult to keep the eye open. So I suggested to my retina surgeon that please let me put lubricating eye drops before doing laser, because once it starts getting dry. And so would you recommend the same thing for
So in babies we are washing with saline or with lubricating drops. The problem with lubricating drops is that if it is not a good quality, which now sometimes we are not getting that goniosolol and all, then it sort of sticks and then we don't know how the focus of the beam is there. But most of us are using ringer lactate or BSS. We should not use normal saline, but some people are using it as substitutes. So fortunately for babies, we are always keeping it under irrigation. We are not, asking the baby to blink to.
I do it regularly under tear substitutes. I don't have any issues with them.
Thank you so much.
Okay, I think we'll go to the next talk and we can take the next questions. So I'm going to talk about stage 4 and beyond surgery, and these are the lessons that I have learned over the last 17 years. Okay, and I don't have any personal funding, but yes, LV Prasad does get a lot of funding from NGOs to improve the newborn eye care across the country. So, we are fighting a disease which, as I have just told in my last session, that, the retina was healthy. It started with a good visual acuity or a potentially good visual acuity at birth. So the retina was attached, the media was clear, child had good foveation, and the wiring was just starting. So the retinal detachment in ROP is different from congenital cataract and congenital glaucoma, where the period of amblyopia is very strict. But here the detachment occurs after 6 to 8 weeks of birth. So that wiring has just started, and so we should never ever forget that they are going to have that, and then the retina detaches, and there is no optic atrophy, there is no ischemia in many parts of the retina. So it's not a dead retina which detaches. It's not. That's not what happens. So here we have one of my earliest cases. A child came with neovascular glaucoma at 6 weeks in the left eye that was already blind. This was just when I had started my screening, and in the right eye, he just came with some ROP. I don't even know what it was. I just put some laser somewhere, and then I saw that the retina was started to detach. I sent to Dr. Gopal. He did a belt buckle for this child, and then at 4 weeks after surgery, we started refraction. He had -7. He was in glasses. He was under very strict early intervention program, and you can see here, at 5 years his handwriting was better than mine. Today he is a university student. He was the school topper in science, and you can see that the retina, if you would look at the disc and the macula, you would think what potential this child has for vision. But you can see, he has 21, 25 and 12, and as per the the cryo-ROP study, this is a success because retina did not detach or whatever, and patient has 20, 200 or better vision. But this is not what we are aiming for. We are trying to get the best possible vision. So yes, we can have certain cases which respond to belt buckle, and still occasionally I do belt buckle, but it's not something that we do very commonly. More important learning curve is, so this is a patient with APROP. I have done good laser. There was some hemorrhage. I thought, okay, it's not going to worsen, but see what happened. The nasal retina started detaching. And again, I thought, I can wait, because we are taught in diabetic retinopathy that, when the macula starts detaching, only then intervene. So we just waited and see what happened. So this is what I started with. I added some laser. I did some posterior laser. So it seemed as if the disease is going away, plus has gone. But see what happened. And distance between this and this is only 1 week. I was horrified, in 1 week this is what happened. Okay, I went ahead and did a lens sparing vitrectomy, but now on hindsight I think this is where I should have operated. I should have been bold enough to go here when everything was very easy in terms of surgery. So the challenge is how to balance, because between this and this surgery there was 3 weeks, and 3 weeks is huge time for the anesthetist and the neonatologist. They don't want to operate 1200 gram baby or 1400 gram baby. They keep on pushing me, madam, please wait till baby reaches 2 kg. But that 2 or 3 weeks will totally change your disease outcome, and if you wait for another week, it will touch the lens, and then you cannot do lens sparing, and if you make the child a phakic, the prognosis 90% it goes down. So you have to find that optimum time of operating these lens sparing vitrectomy. They're very grateful surgeries, they get very good vision. Only thing is you have to learn the technique and learn to be ready to go in very tiny babies. So that takes a lot of time, and now we are very proud. We have the first NICU in our eye hospital. We have interventionists, we have neonatologists on the job there every day, and every day I'm operating 1200, 1100 gram babies, 8-10 cases, bilateral surgeries we are doing for the stage 4A, and it's very good because you operate and then the disease goes away. The complication rate is much low. So this is what we learned after that case. So here we see the retina has just started to detach more than 2 or 3 clock hours. You do a surgery, lens sparing, just shave the vitreous in 2 or 3 weeks. Everything is fine and your treatment is over. So here you can see other patients. So when we do the surgery, we leave a rim of the vitreous. We don't create a PVD. We add laser or peripheral cryo, whatever is needed. And our aim is to remove all the anterior-posterior traction, the circumferential traction and the tangential traction, and the retina falls back. And the plus also goes away because you've removed all the VEGF. Now if you have a very vascularly active child with 4B or 5, then I usually like to give anti-VEGF 1 or 2 days before surgery so that the bleeding is less. And of course, if there's any avascular retina which we can see, we should laser. So if you are in a practice and you're doing good laser and you find a child coming to you with 4A or 4B, immediately do the laser. Get their hemogram done, get the transfusion done. 90% of these babies come to us with hemoglobin of 6 and 7. They cannot be taken up for surgery, and it's very difficult for them to stay 3-4 days extra in a new city and search a new NICU for transfusion. So if somebody calls me, I say get the hemogram done, get the GA fitness done, and then send the baby. Within 24 hours we are able to take up for surgery all the cases. So as far as stage 5 is concerned, so this is some data we have. Out of 8,000 babies we saw, the prevalence of stage 5 was about 4%. And almost all of them are bilateral blind. 23% came to us with corneal scarring. So they are coming at 8-9 months when the cornea has scarred. Normally ROP should not cause corneal scarring when the stage 5 starts. Corneal scarring means it was left untreated, the lens moved forward, there's a lens corneal touch, and that is why the cornea scarred. So you can see here how late the babies are coming. And 3 to 7% showed calcification or subretinal cholesterol echoes, and these eyes cannot be operated. And of course 1/5 of them were non-paying, but 4/5 are paying patients. So it's a disease of middle income and high income group. And mean age was 9 months. The retina detaches at 3 months. So you can see the scenario that, it's just like, as I said, endophthalmitis patient coming to you after a month, or a trauma patient with PL plus minus coming to you after a month, then you cannot give a good outcome. So we should remember that these are tractional detachments in over 90% cases. Few of them have an exudative component. A large majority are bilateral. It starts by about 2 or 3 months of age, and as soon as we detect, that is the time it should be operated. Of course, it has various configurations. There are certain differential diagnoses. But stage 5 is not a static disease. Now, the literature doesn't tell us this, that stage 5 is a progressive disease. The retina detaches, and then it keeps on worsening because of subretinal exudation, because of lens diaphragm moving forward, the AC becoming flat, a secondary glaucoma developing, a corneal scar developing, and sometimes phthisis developing. So the vision and the potential vision progressively decline even in stage 5. It's not like, okay, now it's stage 5 and nothing is going to happen, or it's like doomed to be phthisis. No, it is active and progressive disease. So the unoperated ROP detachments keep on progressing. They lead to complete destruction of the ocular tissue. So it's like a fire brigade saying that I am not going to douse the fire because the building may not be salvaged. So like there's a huge inferno, so why should I try to salvage that fire? Anyway, the building is going to burn away. So that should not be the attitude. So I'm telling the retina surgeons, will you not operate a PRE necrate eye with endophthalmitis or panophthalmitis? This is the vision 2070. Will you not operate the suprachoroidal hemorrhage beer who has mauled this patient? You can get a 2400 vision. So you're not going to leave because the underlying tissues are still living and they have a potential. And so what is important is to do a good examination under anesthesia and see what is the potential for vision. This is a patient who has come with neovascular glaucoma and I had to do a TSCPC. So this is not what we want to see. What you want to see is this, stage 5, it has just started, lens is clear, there's an early traction, you can operate, and you can get a good retinal reattachment and also functional vision outcome. So if you have a corneal scar, then there are 2 methods, both I do. Either you can remove the lens and leave it alone for the first sitting, the cornea clears by 2 to 3 weeks, and then you do the RD surgery later, or you can do a combined surgery. I'm very proud to have done the first open sky vitrectomy here, which I learned from Dr. Hiroshi, and you can see that you can do this surgery and open the funnel and the retina attaches, and you of course need your corneal person to help you. So I don't do surgeries where there's complete closed a thread-like funnel there, or it is a unilateral stage 5 and the other eye has a very good retina, because then it doesn't help, or there are oculocoat scalcification, or the child is beyond 2 years of age because the retina reattaches because the globe grows. So if the globe is not going to grow, then these folds of retina are not going to reattach. So there is a sort of age limit. And of course the functional success should not be measured by your vision status at 6 weeks or 8 weeks or 12 weeks. So what we find is that they have a progressive visual development and improvement with early vision, and the vision what we are trying to see, like what is the child seeing, is at 5 years, 8 years, 15 years, and I have 15-year-olds who are operated and not operated. When I ask them what do you see, they're so happy. They say, I can identify colors, I can identify, the contrast of objects, whereas the person who was not operated and went into neovascular glaucoma has no PL, and his whole eye is also